Thank you very much, Dr. Rayaj, and thank you, Dr. Khalid, for these very nice words. It's really an honor to be invited to give these lectures, and I'd like to thank Sindar, who I believe is the president of the NNF in the Emirates, and also Monica Kausal, who's the secretary, and who I met in Delhi in March, and so I'm very grateful to be asked to speak to you. I've been to the Emirates several times. I always have a good time there, and I've been to many of the Gulf countries, and I have many friends in this region. So that's why I was very happy when I was asked to give a lecture. So my first lecture will be about recitation and delivery room handling. Originally, I suggested to talk about delivery room handling, but then they also wanted some recitation, so I tried to make a synthesis of this. Here are my disclosures, and of course, I will not be able to cover all aspects during 40 minutes, but I'll try to cover some of what I think are the important and interesting topics. So here is the outline. At the bottom you see that oxygenation. I will not talk about that in this lecture, because that I will cover in my second lecture. So just a short introduction, and just want to remind us all that, as you all know, that the most dangerous day in our lives is the first day, and this is illustrated here when you see how many newborns who die the first day compared with the rest of the neonatal period. Do you hear me well? Do you hear me well?
Yes, we can hear you.
Oh, thank you. So here I've tried to estimate the need of intervention in the delivery room, and I'm sure many of you have seen this before, but I think it's worthwhile to repeat it. So I have gotten the numbers from Ilcor and from other sources. So it has been estimated that between 130 and 140 million newborns are born every year in this world, and all of them should be assessed. At birth, they should be dry, they should be kept warm and positioned correctly. Approximately 15 out of 100, around 20 million babies, perhaps, they need some stimulation in order to start breathing. Just some drying or rubbing the back, for instance. And airway should be cleared only if needed. I'll come back to that. Between 3 to 5 per 100, maybe more in low-income countries, but 3 to 5% would need bag and mask ventilation in order to start spontaneous respiration. And according to Ilcor, 2 million, 2 per 100, a little bit more than 2 million, need endotracheal intubation. I find this number high, but this is what I've seen Ilcor is giving up. Not that many needs chest compressions, less than 1 in 1,000, and the same number need adrenaline, and very few need volume expansion. Now we are talking about basic and advanced resuscitation, and everything above this red line represent basic resuscitation, and under is advanced. That includes endotracheal intubation, chest compressions, adrenaline, and volume expansion. Now, one of the most important diagnosis regarding need of intervention in the delivery room is asphyxia. And as you can see here, there is a wide variation in the incidence from high-income regions, 2.5 per 1,000, to sub-Saharan Africa, 18 per 1,000. And also mortality varies a lot. But fortunately, the mortality due to perinatal asphyxia or interpartum related events has been substantially reduced since the turn of the century, more than 50%. And I think that is also good news that more children survive. I tried to estimate how many babies can be saved by resuscitation. And in our own material from the 90s, there was a mortality of 20% in low-income countries. And it was estimated at that time that 4 million newborn babies suffered from birth asphyxia. Now in Western Europe, the mortality for the same condition is 2%. So if we are able to reduce the mortality to the same as we see in Europe, Western Europe, we could save approximately 700,000 babies. In addition, and it's been shown that up to 30% of stillbirths, and that's more than 1 million of those every year, can be saved by ventilation, resuscitation. That's another 300,000. So that adds up to approximately 1 million newborn babies. And that's an enormous number of potentially saved lives, of course. I will show you some very recent data from a European database called eNewborn regarding outcomes and need of resuscitation of low birth, less than 32 weeks, and extremely low birth weight infants. We just published these data in pediatric research a couple of months ago. So in this database, we have almost 40,000 babies with the gestation age 32 weeks or less. And here you can see how these are distributed to different gestational ages with a peak around 31 weeks. And here we have the neonatal mortality. And you see that it's an exponential increase in mortality with decreasing gestation age. So there's 60%, more than 60% mortality with 22 weeks, but you see there's a very rapid decrease in mortality, and here after 31 weeks, it's a very low mortality. Here we have the odds ratio for mortalities, and for 23 weeks compared with 32 weeks, it's almost a 40-fold increased mortality. We also know that gender plays a role, and we are able to show that, as you can see here, that females have a better outcome, have a lower survival than boys. And also growth retardation seems to play a role, especially extreme small for gestation age, less than the 3rd percentile. They have an odds ratio for death which is between 4 and 5. And you see here small for gestation age defined as less than the 10th percentile. Also has an increased risk, but it's quite moderate. What is the effect of antenatal steroids? Well, we know that antenatal steroids reduce mortality, but what we could show is that even an incomplete course of antenatal steroids has almost the same effect as a complete course. And that means that even if you don't have sufficient time to finish a full course of antenatal steroids, give steroids, because it has an effect anyway. So how many of these babies need resuscitation? Well, when you look at the smallest babies, almost 100%, 95% need resuscitation, and you see how it drops here up to 32 weeks. Basic resuscitation, not many of the smallest babies need basic resuscitation, but that increases with gestation age, reaching a peak here around 31 weeks. And the reason is that, of course, the most immature, they need advanced resuscitation. 90%, approximately 90%, even more, need advanced resuscitation. Now, what we could show in this very large cohort, almost 40,000 babies, is that those babies who were given basic recitation, bag and mask ventilation, oxygen, they didn't have an increased risk of death, which I think is very good to know. However, as soon as you need advanced recitation, mortality increased almost twofold, which of course is not a surprise, but here we can quantify it. Now we talk a lot about the golden minute or the golden minutes, and we know, all of us, that what we're doing in the delivery room is so important for the newborn baby for the rest of his or her life. And here I listed some of the interventions we're doing during this brief period: cord clamping, we're applying PEEP, surfactant, temperature control, oxygen, and so forth. But of course, also what we're doing in the postnatal period is of importance, but here it's so fundamental for the outcome. But also antenatal factors are of course of interest and importance for outcome. I listed 3 here. I could list more, of course. Body mass index, antenatal steroids, mode of delivery. Some years ago we published a meta-analysis in JAMA, where we were able to show that if maternal BMI increases, perinatal mortality increases also, as you can see here. So is this of interest for neonatologists? Yes, it is, I think, because we can educate women and girls, say that it is important for the outcome of your pregnancy, how your BMI is. What about C-section? Well, it has been estimated that as long as the C-section rate is at least 10%, there's no further decrease in mortality, as shown here. But if it's less than 10% in a community, mortality increases. So that means that an optimal C-section rate, at least when we're talking about mortality, is maybe between 10 and 15%. And we also know that there is an increased morbidity after C-section. Here I listed serious respiratory morbidity, and you see all the way up to 39 weeks there is increased morbidity after C-section. So I think that we as neonatologists, we have an important task here to inform and to talk with our obstetrical colleagues, and also to give information to pregnant women and to the society that we want to keep the C-section rate low. And as you know, in many areas of the world, it is way too high. So let's go to the Ilcor recitation algorithm. This is the algorithm from 2010. And in 2010, the so-called golden minute was introduced, the first 60 seconds of life, and it was split up in 2 halves here, each of 30 seconds. There was only one problem with this concept, the golden minute. Ilcor had forgotten to define when is the golden minute. So I started to ask people when I was traveling around giving lecture, and I asked people, when do you start the clock? And I got many different answers. Some said when the shoulders are out, when the cord is cut, or when the baby is on the recitation table. I think we should agree on one definition when we start the clock, and that is when the whole baby is out. Especially when we are talking about the golden minute, it is important to know what a golden minute is. And also when we're giving APGAR scores, we have to know that we're doing exactly the same all over the world. So according to the 2010 algorithm, you should ask 3 questions to each and every delivery. Is the baby born at term? Is the baby breathing? And how is the muscle tone? And if you answer yes to these three, the baby should be provided with routine care here. And if those of you who remember the old algorithm, you had to, the timing was changing every 30 seconds. You had to go from one task to another. That was very stressing, very difficult to achieve. Now, it was only the first 60 seconds that were timed. And also very important, in 2010, Ilcor suggested or recommended that recitation should be carried out with room air instead of 100% oxygen. So what is the indication for starting bag and mask ventilation? Well, it is heart rate less than 100 beats per minute, and or apnea or insufficient breathing within 30 seconds after drying and stimulation. So here is a close-up of what we are supposed to do during the first 60 seconds. So the first 30 seconds, the baby should be dried, kept warm, wrapped into plastic if it's less than 28 weeks. We should stimulate the breathing, position the airways correctly, and we should have recorded heart rate and breathing rate. During the next 30 seconds, respiratory support should be established if that is needed, and we should also have put on a pulse oximeter if that is available. Now the question is, are we able to do that? Well, there was a study published some years ago now from by Lisa McCarty in Dublin. It was a collaboration between Melbourne and Dublin. And here they listed all the intervention that we might carry out in the delivery room. And you see here how many of these were carried out in this study. 97% had a pulse oximeter, heart rate available, 96%, and so forth. And now they timed it and were able to show that we are not able to do this within the golden minute. Babies who needs to be put into plastic, immediately, that happened after 61 seconds. The first heart rate auscultated after 62 seconds. I was surprised. And first available heart rate after 70 seconds, and so forth. And here they have put up some of the interventions that should be performed within 30 seconds or 60 seconds. If you look here, well, most of the baby, 94%, were on the recitation table within 30 seconds, and all of them within 60 seconds. In bag, only 7% after 30 seconds, half of them after 60 seconds. Auscultation, heart rate, 7% only after 7 seconds, and a little bit less than half after a minute. First heart rate obtained after 3 and 33, 3% after 30 seconds and 33% after 60 seconds. So this is surprising, but I think that it demonstrates that it is difficult to achieve what we want to do during the golden minute. So maybe we have to redefine that period. For instance, in the Helping Babies Breathe algorithm, this is what you're supposed to do in the golden minute. Now, suctioning has been removed in the second edition, but you see that you should be drying, stimulating the baby, start ventilating, and assess the baby within 60 seconds. And it's difficult to achieve that. So 5 years later, a new algorithm came out, and it's not so different from the 2010 algorithm, except that they have now introduced maintain temperature line here to remind us how important it is to keep the baby normothermic during the whole procedure. And now they have this golden minute is not split up into 2 halves. So how should we assess the heart rate at birth? Well, in 2015, Ilcor suggests that the heart rate immediately after birth should be determined by ECG. There are other means to do that, as you know. Palpitation of the umbilical cord, use a stethoscope, pulse oximeter, ECG. Which of these should we choose? Because I was critical to Ilcor when they suggested ECG, because it had not been tested out in bigger studies. And also I asked the audience when I travel around and asked, do you have ECG in your delivery room? And at least until now, very few centers have ECG. It might change, but that was the situation around 2015. Now, Camlin and co-workers from Melbourne, they have made an assessment of how to measure heart rate compared with ECG. And here is auscultation, and here is palpation. And you see that both auscultation and palpation, they underestimate the heart rate compared to the ECG, and palpation more than auscultation. And the same authors, they correlated heart rate measured by pulse oximeter up here versus ECG. And you see there's a very nice relation, except we have a lot of babies here in this corner where the pulse oximeter is not measuring the correct heart rate, at least not correct compared with ECG. And some years later, Van Vonderen showed that the blue lines here, pulse oximeter heart rates are lower than ECG. It underestimates the heart rate compared with ECG. So heart rate by auscultation is inaccurate and underestimates the heart rate obtained by ECG. Together with Roger Soll in Vermont in US, I wrote a commentary about this, and we suggested that instead of counting 6 seconds, you can count the heart rate 10 seconds. So much of this inaccuracy could be eliminated. It seems that a reliable heart rate is obtained earlier with ECG than with pulse oximetry, and in one study it was a 84 seconds difference. But on the other hand, quite a high percentage of the ECG signals have to be excluded due to technical problems. So I think we are waiting for new technology, for instance, Bluetooth technology, where we can measure easily the heart rate, for instance, by using cell phones and so forth. So in 2016, Roger Soll and we wrote, I don't know if you agree with me, but we wrote that auscultation is still the gold standard for assessing heart rate at birth. So what about suctioning of the baby? Is it sufficient to wipe the baby? Well, in 2010, Ilcor said that, recommended that routine intrapartum oropharyngeal and nasopharyngeal suctioning is not needed, even for babies born with clear or meconium stained amniotic fluid, as long as they were quite active. And the reason for that is that if you suction a baby routinely, as been done here, the oxygen saturation is lower, up to 6, 7, 8 minutes compared with those who are not suctioned routinely. And some years ago, Walter Carlos and his group from Alabama, they showed that if you just wipe the mouth and the nose with a towel, for instance, it has the same effect as suctioning, at least when they assessed it by counting the respiratory rate the first 24 hours. So we don't do routine suctioning anymore. What about need of ventilation? Well, I mentioned that the indication is bag and mask. The indication for bag and mask is heart rate less than 100 and/or apnea. And then you should ventilate for 30 seconds with a rate of 40 to 60. And the response is how the heart rate increases. Now, if the heart rate is above 100 and the respiration is sufficient, you could stop ventilation. If it's between 60 and 100, continue ventilation, consider intubation. And if the heart rate is less than 60 and not increasing in spite of adequate ventilation, you should start with chest compressions. And then ventilation rate is 30 and it's 90, chest compression is 3-to-1 rate, 120 events in each minute, which is, it's difficult to achieve. So before we talk more about ventilation, I just want to remind you about the correct way to position a mask. You should roll it from the chin tip and see that it covers the mouth and nose. It should not be too big and not too small. And you should hold it with a 2-point technique, as shown here, between your thumb and your index finger. And then you should lift the chin forward. And that requires some skills and experience. It's not always easy. Ilcor in 2015 recommend to start with CPAP for preterm babies who are breathing spontaneously instead of intubation and intermittent positive pressure ventilation. What about sustained inflation? I don't know if any of you are using that, but it has been very popular in many places in the world. But Ilcor suggests against the routine use of initial sustained inflation, defined as inflation more than 5 seconds duration. There was a Cochrane review some years ago, now 3 years ago, when they looked at sustained inflation versus more standard ventilation. And they couldn't find that the sustained inflation reduced mortality, the need for intubation, need for a duration of respiratory support, bronchopulmonary dysplasia. There was actually no evidence of relevant benefit for sustained inflation over intermittent ventilation. And then the SAIL study was published. The SAIL study was a study recruiting babies between 23 and 26 weeks in need of positive pressure ventilation at birth, and they were randomized to a sustained inflation group. 15 seconds, the first inflation was 20 centimeter water, and the second 25. Now this study was stopped before it had finished, because it was clear that the early death was significantly increased in the sustained inflation group, 7.4% versus 1.4% in the control group. So what about cord clamping? This has also been a very hot topic the last years in neonatology. If you measure by just putting a newborn on a scale and see how fast it gains weight, that reflects the transfusion from the placenta into the baby, we can see that after 60 seconds, approximately 70% of the transfused blood has reached the baby. And if we wait another minute, we see that almost 90% of the transfused blood has reached the baby. Now, the interest for early or late cord clamping is not new. When I prepared for this lecture, I found some studies more than 50 years ago, which was summarized in this review article by Moss and Monse-Courard, published in Pediatrics in 1967. And they were interested in hemodynamics, and they could show that late cord clamping resulted in a higher pulmonary arterial pressure, at least 9 hours after birth. So this is not new. And today, I think all international organizations, bodies, they now recommend delayed cord clamping, 32 seconds to 1 minute in preterm babies and also term babies, of course. So 2 or 3 years ago, this study was published, Australian placental transfusion study, the APT study. And this study, the aim was to compare death and morbidity at 36 weeks in 1,600 babies, a very large study, born before 30 weeks gestation. And they were randomly allocated to immediate cord clamping within 10 seconds of birth versus delayed cord clamping, which was 60 seconds and more. And what they showed in this study, which was published in New England Journal of Medicine by William Tarnomori as the first author, was that there was absolutely no effect on the primary outcome, which was death or major morbidity by 36 weeks of postmenstrual age. However, when they looked at death alone, they found a 30% reduction in mortality in those who had a delayed cord clamping. So based on this, the authors also carried out a systematic review and meta-analysis. So they found 19 clinical trials where babies had been randomized to delayed clamping versus immediate clamping, and they only looked at babies less than 37 weeks. And what they found was exactly the same as in the APT study. There was a 30% or 32% reduction in mortality after delayed cord clamping. So here is some details of the study. As I mentioned, 19 trials, almost 3,000 babies. It's a large study. Relative risk ratio for mortality 0.68 in the delayed cord clamping group. Number needed to treat to benefit was 33. Well, regarding secondary outcomes, delayed clamping reduced the number of blood transfusions given. It increased polycythemia and also jaundice. And other secondary outcomes was no change between the two groups. Now the next question is it possible to resuscitate with an intact cord? Kateria and co-workers for San Diego, they tried to answer this question with a randomized clinical trial where they recruited babies between 23 and 31 weeks. This was published some years ago, and here is a range of variables, hemodynamic variables, and I will not go through this, but as you can see, there was absolutely no difference between those who had been resuscitated with an intact cord versus those who did not have an intact cord. So Kateria and co-workers, they concluded that it is feasible to resuscitate with an intact cord, but so far there's no improvement in outcome. What about cord milking? Well, that is a fast method to transfuse blood from placenta to the child. So in an emergency, this might be an advantage. So during cord milking or cord stripping, which is also called, the cord is cut at about 25 centimeters from the umbilicus within 30 seconds after birth, and then it's milked 3 times at a speed of 10 centimeters per second. Now, in one study, cord milking versus immediate cord clamping was compared, and it seemed that cord milking was giving better outcome. These are babies between 24 and 28 weeks. Less need of transfusions, 83 versus 97, higher hematocrit, and less intraventricular hemorrhage, 25 versus 51%. And also grade 3 and 4, there was not a difference here in this study. So another study, cord milking was compared with delayed cord clamping, and it was not found any significant differences between these two methods. Kateria also did a study in babies between 23 and 31 weeks. And what he could show was that those babies who had been treated with cord milking had a higher cognitive score at follow-up, 100 versus 95 in the delayed cord clamping. So that was, of course, very promising. Also, language score was higher. However, when we look at the intraventricular hemorrhage rate, it is increased substantially, a fourfold increase in intraventricular hemorrhage, especially for the smallest babies after cord milking. So I think this study kind of killed every interest in cord milking among the most immature babies. So what's happening here is that this is how you do the milking 3 times, and this increases the venous return to the right atrium, and it enters the foraminal valley and the aorta, and as long as the lungs are constricted, you know, if there's a lack of cerebral autoregulation, which it is in preterm babies, and there's a right to left ductal shunt, this may result in fluctuations in flow and an immature brain with fragile germinal matrix. This may lead to intraventricular hemorrhage. So this is one way to think about that. And then what about physiological cord clamping? Ventilate and then tap the cord. Well, this has been studied by several authors, also actually 50 years ago, but Stuart Hooper in Melbourne have studied that both in animals and in children. And here is an animal study showing that if you clamp the cord before you start ventilation, you see here the blood pressure increases and the carotid blood flow increases like this. By contrast, if you wait to clamp the cord after the start of ventilation, you see this smooth transition, much more hemodynamically stable. I think that this is what now people are aiming at, is to do such a physiological clamping. And finally, just a few words about heat loss and temperature control. As I mentioned, Ilcor in 2015 introduced this temperature line to remind us how important it is to keep the baby normothermic. So in order to prevent heat loss, the most immature babies are put into occlusive wrap, into plastic bags before they're dried in order to reduce hypothermia. And hopefully this results in decreased morbidity and mortality. Or is that the case? Well, before I go on, I just want to show you the most recent European guidelines for babies with RDS. Came out a year ago. It is to maintain core temperature between 36.5 and 37.5 at all times. And we should keep it quite warm in the delivery room, and the obstetricians don't like that. Less than 32 weeks, 23 to 25 degrees Celsius, and less than 28 weeks, 26 degrees. Now, very recently, a Cochrane review came out comparing plastic wrapping versus routine care. And yes, they were able to show that the core body temperature was higher when the babies are put into plastic, as shown here. But there were also more babies with hyperthermia in this group. So this is, of course, concerning. Excuse me. When it comes to major brain injury, there was absolutely no difference between the groups. And when they looked at death within hospital stay, it seems to be a small advantage of plastic wrapping, but it's not significant. But when they looked at the data again, when the babies were 6 months, there was absolutely no difference in mortality, whether you put the babies into plastic or not. And of course, that was disappointing. The same was shown in this study from US by Maureen Rayleigh and co-workers. You are able to prevent hypothermia by putting the babies into plastic, but these authors did not find any effect on mortality of the wrapping. Odds ratio 1.0. It was less pulmonary hemorrhage, of course. So plastic wrapping reduces or leads to higher temperature at admission with less hypothermia. But we have to be careful because it might increase hypothermia, especially if you combine it with the thermal mattress and skin-to-skin care. And there's limited evidence that it is of benefit and do not give any harm. So in spite of the fact that many studies have shown increased mortality among preterm infants who are hypothermic, we don't have evidence enough to say that these interventions with plastic wrapping reduces in-hospital mortality. So maybe hypothermia is a marker for illnesses and poor outcome by association rather than by causality. So I will just end up now with some recommendations from the World Health Organization that was that were published 5 years ago. I was so fortunate to be on the panel making these recommendations, and this is what WHO ended up with, that they put a lot of emphasis on kangaroo mother care. It's important, and it should be provided as close to continuously as possible. And if it's not possible to do it, it is better to do it intermittently than not doing it, according to WHO. So I will end up with some of the recommendations, the European recommendations for RDS. As a summary of this lecture, so we aim at the delayed cord clamping at birth by at least 1 minute. We stabilize preterm babies less than 28 weeks in plastic bag under a radiant warmer to prevent heat loss. But we have to know that it probably doesn't reduce mortality, and we have to be aware of the possibility of hypothermia. We prefer CPAP instead of intubation, if possible. And here's the pulse oximetry. I will talk more about that in next lecture, so I skipped that. And intubation at birth should be considered only for those not responding to the above. And I haven't talked about surfactant in this study. So with this, I will thank you for attention and show you some nice view from Norway, a greeting from my country. Thank you very much.